Hi listeners, my name's Narinder Singh. I'm the founder and CEO of Look Deep, and I want you to meet Amy.
Thanks, Narinder. I'm an AI assistant that can see. I was created by Look Deep, the first company to bring peer-reviewed computer vision into hospitals.
Amy watches for signs that a patient needs help, supports the care team, and makes sure no one ever feels alone in their care.
I'm sure you have questions. I'd love to answer them. Come talk with me at lookdeep.ai/Amy.
Welcome to the Heart of Healthcare podcast. I'm Hallie Tecco.
I'm Michael Esquivel.
And I'm Steve Krause. And every Monday, we bring you the latest in healthcare innovation as we sit down with entrepreneurs and industry experts.
So buckle up and join us as we figure out how to improve healthcare for all.
Hello, listeners, and welcome back to the Heart of Healthcare podcast. I'm your host, Steve Krause, and excited to be joined today by our co-host, Michael Esquivel. Michael, how you doing? Happy September.
Happy September, Steve. Excited. Back to school, back to the grind.
It does feel like back to school. So we'll get back to the news since it's that type of theme for this month. We are in the month of September. We're talking about news from the last couple of weeks, our monthly digital health download. And I think we couldn't talk this month without talking about Epic, the 800-pound gorilla in the healthcare space. They had their annual users group meeting last couple of weeks, Michael, where, surprise, surprise, AI was the star of the show. There was lots of speculation, lots of rumor, lots of talk about what Epic was going to release at their UGM. This is a conference that they have for lots of their major customers in the industry. Very typical Epic. They had they actually rolled out over 200 AI features, including their own foundational model that they call Cosmos, including their own digital scribing tool, which is called Art, was about aiding clinicians in many different ways, one of which was sort of scribing other use cases, and then Penny, which automated billing tasks. Very cute name, Penny. And so, yeah, I mean, this was made a lot of news. Epic, as I said, is the 800-pound gorilla. They have so much distribution. The question, I guess, is can they get all 200 AI features and products right? But if they can, they're pretty uniquely positioned to push them through their chassis, their distribution chassis. So, Michael, I'm sure you heard about this from the clients you work with, the companies you work with. What was your take on Epic and the road ahead?
Yeah, it was quite an announcement, right? I mean, 200 different, I think they call them digital colleagues, I think is what they refer to them. But in any event, it is going to be a very comprehensive solution if what you said a moment ago, Steve, comes to pass. They get it right. And it obviously raises very interesting questions from some of the companies, Steve, you and I have the privilege of working with, like Abridge and Ambiance. But the if is a really, really important question that they need to nail here. Will it be perfect? Will doctors complain about hallucinations, formatting quirks, time wasted fixing notes? These are the kinds of, there are companies just dedicated to elements of this end-to-end solution they're trying to create here. So it really jumped out like if they can get it going, I think it could be very, very interesting. But even their model, I think, Steve, is going to be more general purpose. There's leaving a lot of white space for specific, specialties, oncology, behavioral health, women's health, et cetera. And so I'm very, very curious if they're going to be able to actually provide a model that is really, really centered on supporting these very specialized domains.
Yeah. It's really interesting. We're having this debate at Bessemer, and I think entrepreneurs and VCs across many different industries, not just healthcare, are having this debate. For the first time ever, because of these agentic LLMs, I think systems of record, whether they be an Epic or a system of record in the restaurant industry or in the construction industry, I think they're actually at risk for almost being surrounded by what are our systems of action, right? Because, and it'll be really interesting to see how this plays out in healthcare, because we have like one of the most dominant systems of record in Epic. They have just amazing amount of market share. And there's a lot of money being poured into these LLM-driven companies that are actually doing tasks, right? I mean, if you think about Epic, doctors hated Epic, even though they were able to buy it for free and it's been around for a long time and they needed to put the data in to get reimbursed, right? But you never heard a doctor saying, I loved Epic. Whereas now with like Abridge and Ambiance and other technologies, like that's actually taking these conversations that happen naturally and automatically populating the electronic record. And it's actually made software delightful and easy to use for doctors. And those are action-based systems by definition. So the question is, are those systems going to win? Because they're going to surround the system of record and they're going to, as you said, build best of breed solutions that start to, almost like an octopus, start to entangle the system of record. And ultimately, do you have more loyalty to your system action than you do your system of record? Or is the system of record, Epic in this case, just so powerful, it has so much of the data, it's so hard to rip out, that they say, not so fast. We're going to own this and we're going to tell our clients to wait for our products we develop. Or do they figure out that they're going to cooperate? And I think it's going to be really interesting to see how this plays out. I don't actually know. It's going to, this has happened in every industry, but I think healthcare is one of the most interesting because Epic is just so powerful.
Yeah, and I think you're spot on there, Steve. The other thing that's interesting is, look, they are the 800-pound gorilla, but let's not forget there are other platforms out there. Not every provider runs Epic, right? We've got obviously Cerner, Oracle, we've got MedTech, Athena, smaller EMRs, et cetera. And so what's interesting about some of the other solutions, the Ambiances, the Bridges, is they're cross-platform, right? And so you're not sort of keyed in on just using the Epic tool with those solutions. So you're right. Is the system of record going to win out on this battle, or is the system of action? And I do wonder if Epic is going to be able to deliver the same quality product that you're seeing from some of those startups that are. Well,
they said somewhere, I read, a year and a half till they roll some of this out. So there's still time for the innovators to continue to take advantage of the market void.
Yeah, but that's another example, right, of where the system of record moves glacially, right? A 12 to 24 month cycle.
I know.
I mean, our startups iterate in weeks. Yeah, not in 12 to 24 month cycles. They'd be out of business if they did.
Yep. All right, what story you got? What's your
story?
Story?
So let's pivot a little bit. Let's talk about CEO comp, one of our favorite topics. As you might have seen, Stat compiled some data on healthcare CEO compensation. It looked at 275 public healthcare companies in 2024. And it noted that the average CEO pay was $13 million and the median was $5.5 million, which were both the highest marks we've seen since 2021 in our broad sector here. 91, that's right, Steve, 91 CEOs crossed the $10 million mark. Now, on first glance, you're going to say, wow, that's just very, very rich. But I will note that when looking at the S&P 500 CEOs, when you look at median total comp for that group across all industries, it was 17.1 million. So median comp was 17.1 million there. It was 5.5 million in the Stat survey analysis that just came out. And it's fascinating because how you actually calculate that CEO comp, and not to geek out as a lawyer, but I will for just one 30-second interval here. What oftentimes these surveys do is they take a look at the summary compensation table that is included in a public company's proxy statement. And the problem with that often is it's a snapshot. You're valuing equity on the grant date. Totally. But as we know, there's vesting, there's milestones. And so it oftentimes can understate or overstate what the actual take-home pay that particular CEO is going to take home when she actually earns it. So what Stat tried to do in this article was they actually looked at a calculation they called the actual realized gains. So they went into the data, and some public companies do in the compensation and disclosure and analysis section of these proxies. They do lay out what some of the realized gains are. So they're not just taking the accounting grant value. But what's interesting about that is even in calculating that doesn't mean just because it's an actual realized gain that this is what that CEO is going to actually take home at the end of the day. So in any event, kudos to them to at least try to move the ball forward and trying to capture what real dollars were involved here. The biggest earners, not surprising to many of our listeners in 2024, was the BioNTech CEO. He took home $301 million. That was almost entirely from actually exercising a 5-year-old option linked to the COVID-19 vaccine. Second was the DaVita CEO. He took home $148 million. And then third was the Regeneron CEO, who took home $124 million. What is a little bit shocking, though, is that the performance of some of those companies in the market has not been terrific, especially compared to some of the peers. And yet the comp was quite generous. And again, just cautioning for the listener, that's their actualized, realized gain value that stat computed. So these were equity awards that were probably given, as in the case of the BioNTech CEO, were given in prior years, but they finally earned them, if you will, in 2024. But it's just fascinating that in our industry, as we've continued to see some suboptimal performance in the public markets of these healthcare stocks, these CEOs are still taking home very, very rich compensation packages.
I'm of real mixed mind here. So listen, I think throughout society, we have massive wealth disparity, and that's regardless of whatever industry you work in. And I think that's just an issue that we're not going to solve here on this podcast. So I'm not going to take that on. But let me say that it's really tough when you're working with one of these companies and maybe you're making a little bit better than a living wage. You're making a decent wage, but you're still struggling to get ahead in society, and your CEO is taking home, I don't know, 3,000, 30,000, 300,000 X what you make, whatever the numbers are. That's tough. That's a tough headline. And then I think the other thing is obviously the healthcare industry has had challenges in terms of public perception. I don't know what it is, because I don't think in healthcare we're worse actors than other industries, honestly. I just think healthcare is so emotional and personal that people can't separate necessarily out the business side of healthcare and then like the do-gooder side of healthcare. It's also why you and I are drawn to working in healthcare. It's like you can do well and do good. But I think those two things, they can be dichotomous at sometimes, and when people look at these numbers. That being said, do I think the guy who led one of the companies that produced the COVID vaccine should make $300 million, which is probably still less than Aaron Judge makes or Jason Tatum makes, or some random singer who has a bunch of pop hits should make, or a movie star should make? I actually freaking do. I don't know. The people who lead these companies, I can tell you, they worked really hard to get where they are. They work nonstop, right? They're leading massive organizations. They've got a lot of pressure. And I can't necessarily say that they should get paid less than Aaron Judge or Jason Tatum. Like they should get paid.
It's a great point, Steve.
The headlines get, the headlines, but I get a little mixed on this one because I get it. I get the wealth disparity issue, but we have it throughout society. So should we pay our healthcare executives what other leaders in industry or other parts of society make? I kind of think we should.
Well, and look, and relative to their peer group across all industries, this is not as material or significant as you're seeing in the S&P 500 group of CEOs. One final point that the stat piece laid out is one key driver is longevity in the CEO seat.
Do you get paid more for longevity?
Yeah, well, if you stick around long enough and the company stays afloat, you have greater chance of earning meaningful dollars, even if the company underperforms.
Yeah, well, I noted, by the way, this might be a positive thing because I noted there was no digital health CEOs on this list. So hopefully, 5 or 10 years from now, there will be one, because that would probably mean a good thing, I would guess.
Yeah, these were all traditional healthcare companies, so you're absolutely right. No digital health CEOs, Steve. So good call out. All right, Steve, where are you taking us next?
Well, okay, so this is going to be one of the reasons why healthcare CEOs aren't loved. And actually, I think in this case, it may not be their fault. My second story is I am telling folks, many folks in the industry probably know, but we are headed into a health insurance bloodbath. We're headed into open enrollment period where you're going to be signing up for your health insurance for the coming year, and premiums are not going to be good. I'll explain why. And ultimately, I think this is going to be a driver of the 2026 elections. We obviously know Medicaid is going to be cut and people are going to start to lose Medicaid coverage. We know potentially that ACA subsidies might go away very soon. And so if the subsidies go away, people who aren't covered by a subsidy are going to see their premiums go up if they need to buy individual insurance. insurance. In fact, in Arkansas and Colorado, already there's been a political discussion and negative coverage of rates increasing significantly. Like in Arkansas, in some cases, they increased the ACA rate. So for the individual exchange plans, increased some of them up to 40% in the marketplace, which is just insane, a year-over-year increase. Yeah. And then on top of that, you're going to see increases in the commercial markets. Projections are that there'll be a median increase, the Business Group on Health said, for commercial insurance of 9% in 2026. This is on the heels of 7% in 2024 and 8% in 2025. So year-over-year compounding of healthcare costs.
Yeah, Steve, the healthcare cost surge here is obviously dramatic. What are you seeing is fueling that fire today? And it feels like, and the other, we'd be remiss not to raise one of our favorite topics here. I got to imagine the GLP-1 explosion.
Oh yeah, Michael, you're totally right. In the commercial market, for sure, some of that increase. I said 7% in 24, 8% in 25, 9% projected in 26. Those are all-time highs in terms of over the last 15 years in terms of rate increases on a percentage basis. And a lot of that in recent years is attributable to the cost of the GLP-1s and other specialty meds too, but GLP-1s for sure. Yeah.
For sure.
Anyways, it's going to be an interesting fall. Unfortunately, people are going to feel in the pocketbook, and it's going to be interesting to see how that plays out at the polling booth in 2026, the midterms.
Yeah, the numbers are staggering, Steve, and it's gonna result in a lot of pain for a lot of people. I'm curious and fearful what it's going to do to the uninsured rolls in terms of numbers. It's not great for our country. It's not great for our human health condition. It's just it's not optimal. But certainly the realities of the capitalistic system also are at play here too. All right. Well, maybe on a slightly more positive topic, I'm going to shift us into robots in U.S. hospitals and their ability to fill the labor void. It was a really interesting article I came across that showed that U.S. hospitals are increasingly adopting logistics robots, Steve, to fill gaps caused by the workforce shortages they're experiencing. So these are robots designed to handle non-clinical busy work, delivering medications, lab samples, supplies across the sprawling hospital campuses. Over 30 hospitals have already deployed them, with projections that reliance could grow as staffing shortages worsen. The shortages are estimated to reach 100,000 healthcare vacancies by 2028. So this is a really, really meaningful shortfall that needs to be closed in some manner, and robots might be that solution. Unlike, patient-facing AI tools, which sometimes spark trust issues by the patient user, these robots seem to be more widely accepted because they support staff rather than replace direct caregiving. So hospitals are able to report measurable benefits. Nurses are reclaiming time for patient care. There's fewer workflow delays and reduced burnout. So it's a really interesting moment where maybe robots really try to bridge some of the gap here in not only the workforce shortages, but also in helping our healthcare providers experience less burnout. So it was a very interesting piece, and I don't know if you're seeing this across any of the Bessemer portfolio of amazing companies, but it seems like maybe a really viable next step in trying to solve some of these problems.
Yeah, I love the story. I think the smart hospital is a space that we have been looking at, how to use a combination of hardware and software to automate hospital operations, maybe even automate some clinical use cases. But what I liked about the robots is, in some ways it's weird, like, oh my God, the robots are in the hospital. But in other ways, it's really nice because they're kind of co-pilots, as you make the point, to nurses. They're not trying to replace nurses' jobs. Right. And I think we're going to have to crawl, walk, run our way to automation. And so if frontline workers actually have some positive experiences with automation, whether it be hardware or software, I think that's a good thing as we make this journey, because we're ultimately going to make this journey. It's just going to be how painful 100%. And how much friction there is and how much political pushback. And so I thought this one was really interesting. I mean, this has been tried before. There were RFID labeled, robots in the first generation that didn't really work and the technology wasn't there. But now I'm sure we've all seen the amazing Boston Dynamics, dancing dogs and dancing humans and fighting humans. And so right. Like the hardware software interfaces have become so much more impressive that, to do some of the clerical operational food delivery even. There's a lot of stuff that happens in the hospitals where you could imagine this technology being put to use. So I like it as a first step to get people familiar with these technologies.
Yeah, for sure. I'm going to date myself a little bit here, but it feels like the Jetsons meets hospitals. If you've seen some of these robots, it feels like it comes out of one of those cartoon
Meet Michael Esquivel
series.
There you go.
That's right. You got it.
Okay.
All right, where are you taking us next, Steve?
Well, we're still going to stay on AI and automation. I think beyond the seeing how the system of record, system of action, warfare or cooperation plays out, which is a previous story we talked about. I think this next one of like, how is health AI going to be regulated is just an open question in my mind. And I spend a lot of time thinking about public policy. I know you do. We have to in our jobs.
For sure.
But I saw two stories this week, which were like polar opposites. And I'm just going to share them. And I'm a middle of the road Democrat. I'll tell people that. But this was one from a Democrat, one from a Republican. So Illinois Governor J.B. Pritzker, who, by the way, I love, he just signed a new law, which I don't love, prohibiting the use of AI for mental health, noting that this will protect patients from unregulated, unqualified AI products while also protecting the jobs of Illinois' thousands of qualified behavioral health care providers. Violations result in a fine of up to $10,000.
Yikes.
There's obviously venture-backed companies, a company like Slingshot AI, which is really interesting, that's trying to use AI mental health coaches. And so this is one approach, which I don't love as an innovator because, frankly, AI, I think, should be a tool in how we practice the behavioral health caregiving. It should be, at the bottom end of the tool. It should be able to elevate people to higher levels, like a psychologist or a psychiatrist, and human-based therapy. But we have a clinician shortage. We should be thinking about how we use these technologies. And then on the other hand, I saw this bill, which, by the way, hasn't really gotten a lot of traction in Congress, but it was introduced by a Republican Arizona representative, where it would allow AI tools to legally prescribe medications if approved by the FDA and authorized by states. And I was like, holy cow, well, that's just the other end of the spectrum. I'm not sure I'm ready to go there yet. And we need a lot more details. So I was just, the dichotomy of these two bills struck me. I probably fall somewhere in between. Like, we shouldn't be outright banning mental health AI coaches. We should be looking at them and testing them and coming up with rules of how they should work. They should be maybe approved by the FDA, maybe not, if in conjunction with overseeing physician. But yeah, we're not ready for AI to prescribe drugs. So how this all plays out is going to be really interesting to watch over probably the next several years.
Yeah, what's interesting, Steve, is I've been looking across this sector and working with these amazing startups and companies. I have the privilege of doing so every day. One thing that has become clear when I think about adoption and uptake by incumbent stakeholders, those technologies that supplement the provider and support the provider seem to have greater uptake than those that try to replace the provider or the caregiver. And so the middle ground strikes me as probably the right approach. I mean, I think Illinois has gone too far. I mean, administrative AI is fine, but clinical AI is off limits. That seems silly to me. And then you're right. I don't know if we're quite ready to go all the way to just letting AI do it all, but somewhere in the middle where these AI tools are enabling and supporting and allowing these providers and clinicians to improve their offerings and the healthcare of their patients seems like the right balance, at least today where AI stands at this moment, which is changing dramatically and exponentially every day.
Yeah, we've talked about this dyad versus triad, the triad being physician, AI, patient. I think that's the right approach now, and that's where you're following under the physician's license and judgment in terms of practice of medicine. But the challenge is we need some regulatory clarity. We had Brian Anderson from Chai on the podcast a couple months ago, and he actually wants clarity because these technologies are moving faster than regulators, and they're already dyads, right? There can already be AI physicians that can treat patients, and I worry if we don't get the regulatory clarity, we're going to have some rogue actors, and then it's going to spiral into a negative, cycle for innovation. So anyways, but I don't have a lot of faith, given everything that's going on in our country, that the regulators are going to move fast enough. But man, I just detailed wildly different approaches to how we regulate this stuff. So we shall see, my friend.
It will be interesting to see how this all shakes out. Well, I guess to wrap it up, speaking of AI empowering the patient provider, I came across a really interesting article of a radical reinvention of a classic tool in medicine. Yeah. The stethoscope was invented in 1816. And it just now, 200 plus years later, it just got its biggest upgrade ever. one that could transform the role of GPs in diagnosing heart disease early. Researchers at Imperial College London and Imperial College Healthcare NHS Trust collaborated on a groundbreaking AI-powered stethoscope study that was actually built by a California-based company called Echo Health.
Yeah, I know Echo. Super cool company.
Yeah, very cool. That can detect heart failure, heart valve disease, and abnormal heart rhythms in just 15 seconds. Wow. The device, combines traditional auscultation with a rapid ECG, then uploads that data to the cloud for AI analysis, and then it delivers results instantly to a clinician's smartphone. In the trial, around 12,700 symptomatic patients with symptoms like breathlessness, fatigue, leg swelling were tested across 200 GP practices. And the results were compared against practices using standard stethoscopes. And the outcomes were dramatic. Patients were twice as likely to be diagnosed with heart failure, 3 times more likely with AFib, and almost twice as likely with valve disease when examined using this AI stethoscope tool. But the study did show that the AI tool is really only for patients that are showing symptoms. It's not for routine screening yet, due to the high false positive rates they get on non-symptomatic patients or healthy patients. So that's an interesting limitation. But it was recently presented, and it goes to the old classic: early detection is saved lives and money saved.
Yeah,
and
I think
it's a really exciting technology.
I love Echo because, like you said, this is like a device that was invented in 1816, and it's like, you're as a patient, you're sometimes always wondering, like, is the doctor really hearing anything here? But they're using AI to really get at root causes of key diseases, underlying diseases. And by the way, their go-to-market model was really interesting early on. It was very DTC. They went directly to physicians and actually younger physicians, if I remember correctly, even residents and the like, who were more tech savvy and thought this was a cool technology. And then ultimately they rose up to more of an enterprise sale, from my understanding last time I talked to the company. But I wonder how they're going to monetize this, because if this is actually right, like, this is almost upends how the patient flow for cardiology, right? Like, to the point that you made, GPs could actually start to diagnose and then refer to cardiologists. So I'm just curious, does this work in a value-based care model, do you know? Or is it, I wonder how this is going to change the economics and patient flow in cardiology patients.
Yeah, it's a great question, because obviously you've got some initial higher investment here, but maybe, or not maybe, definitely earlier intervention reduces costly late stage care.
Like, for instance, like a value-based care provider like Oak Street would love this, right? It's so, in our industry, it's obviously marrying the technology, the product service to the business model and the market opportunity. And so I'm very curious to see how this evolves for Echo, because the technology is obviously super cool, right? And so how do then they monetize is going to be interesting to see. But this is like an example, like, the robots are coming. So, they're gonna. We gotta be ready.
Well, and it certainly fits nicely with the thesis earlier that we were chatting about around the human in the loop component, right? So AI is obviously accelerating detection, but it's not replacing the clinician, right? It's empowering and supplementing the clinician's skills. And so it is an interesting example of what we were just talking about earlier.
Right. And do I mind if the Echo CEO, Connor Landgraf, makes hundreds of millions of dollars if he's actually able to the earlier story, to diagnose heart disease for tens of millions of patients early? No, I think that's okay, right? So
and the cost savings, if we can get early detection, Steve, I mean, it's always obviously so much more cost effective to deal with this early than in late stage care scenarios and settings.
Yeah, so Michael,
it's exciting.
We covered a lot of ground here, and I feel like that was only half of the month's stories. It was amazing how much went on last month.
You're here.
I hope your back to school goes well.
Likewise, Steve. I hope our listeners are getting accustomed to getting back into it. I know for me, having the kids back in a routine is a very good thing, and appreciative of all the amazing teachers out there that not only educate our kids, but help the rest of us survive our days.
Here. All right, buddy. Well, we'll see you in October.
We'll see you
soon. Thanks for listening to The Heart of Healthcare. If you enjoyed this episode and you'd like to support the podcast, please leave a rating and review. And don't forget to subscribe. The Heart of Healthcare is produced by Hallie Tecco and hosted by Michael Esquivel, Steve Krause, and Hallie Tecco. The show is engineered, edited, and mixed by Kyle Moore. Visit our website, heartofhealthcarepodcast.com, for show notes and details.
Shopify's point of sale system helps you sell at every stage of your business. Need a fast and secure way to take payments in person? We've got you covered. How about card readers you can rely on anywhere you sell?
Thanks. Have a good one.
Yep, that too. Want one place to manage all your online and in-person sales? That's kind of our thing. Wherever you sell, businesses that grow with Shopify. Sign up for your $1 a month trial at shopify.com/listen. Shopify.com/listen.
Wherever you go, whatever they get into, from chill time to everyday adventures, protect your dog from parasites with Credelio Quattro. For full safety information, side effects, and warnings, visit CredeliaQuattroLabel.com. Consult your vet or call 1-888-545-5973. Ask your vet for Credelio Quattro and visit QuattroDog.com.